In addition, we're also going to talk about the Consolidated Appropriations Act, which is something everybody should pay attention to in terms of ERISA fiduciary duties. That could have a real big impact on how you manage your health plan. So without further ado, I'm going to turn it over to Al Lewis to lead our discussion.
Okay, thank you very much, Mark. I assume everybody can hear us. I would like to personally welcome Chris Deacon to our team of all-stars that we've had for the last couple of years on these webinars, of which she is one. Currently, she's Senior VP at 4C Health Solutions, is best known as being the former director of the State of New Jersey Health Plan, which is about the third or fourth largest health plan in the country and probably the most visible north of Bentonville. She's a Bentonville, by the way, that's just for, that's where Walmart is located, just FYI. She's a self-proclaimed public sector entrepreneur committed to bringing accountability and transparency to the healthcare industry, which is why she's here today. Also served as Deputy Attorney General for the state of New Jersey and Special Assistant Counsel to previous governors, always with a hyper-focus on accountability and stewardship over taxpayer dollars. Before finding herself in healthcare and public service, like me, she is a quote-unquote recovering attorney, practiced at corporate restructuring, which is to say bankruptcy law, in the Mid-Atlantic region. A couple of little factoids about Chris. Her particular passion is mental health awareness and stigma reduction. Very proud of her work with the Quell Foundation, which essentially does exactly that, tries to decriminalize many things that are caused by mental health issues as opposed to true criminal intent. Has 3 young children and yet manages to get everything done. Is also considering a write-in candidacy for the 2024 presidential election. Want to hear more about that, but just a couple of personal questions first. Actually, let's start with a couple other personal questions before I get into this. So scale of 1 to 10, how would you consider your stress level now versus when you're running the state health plan?
It's a good question, Al. I think considering all the external factors ongoing with COVID and being the mom of 3 young kids, and I have to say the stress level has remained fairly constant. It's been quite a challenge as a family and as a mother and as a working mom. That being said, very early on, I've always instituted some stress management techniques like exercise, eating well. So I'm doing my best, but I take a lot on and I enjoy doing that. So always a pretty high stress level, but it's how I manage it that I think makes it okay.
And of course, your kids were home quite a bit of last year as well, right?
Yeah, you might see a couple pop in today due to the Omicron variant. They're now being required to test into school. So I have virtual learners home this week, and fingers crossed they will be back in school next week.
Well, here's hoping,
yeah.
Right? So the question I always get asked about you, and you probably get asked this, I know you get asked this yourself because I personally have asked you, is when you left the state, why not just hang out a shingle and consult? You'd have people lined up around the block.
Well, I don't, maybe you had a lot more faith in me than I did, Al. It's a good question. And I think that my number one goal was to continue to be put in a position where I could continue to effectuate change and take the skill set that I learned at the state. And, I think if I eventually find that hanging a shingle will be the best way to do that, then that's not off the table. But, as a first step, the mission that I had is aligned with the mission that the current company I'm at, which is 4C Health Solutions. So, again, bringing at scale the solutions and the thought that I had at the state was really the idea there.
Well, I have to say, I have looked at your website, and it does look 4C Health Solutions website. It does look very mission driven. were you to decide to go out on your own and hang out a shingle, I would provide the hammer, the nails, and the asphalt if you were to do that. So before we get into the actual substance, which I think probably people are, and by the way, as Mark mentioned, if you have questions, put them in the Q&A, and also use the chat box. But remember, the chat is not going to be followed up on. So what's this about running for president in 2024?
Oh, well, today's a really interesting day in American history as we commemorate January 6th of last year. But, I write that half in jest, but also with some seriousness. When I was in kindergarten, I think I told you, Al, my idol was Ronald Reagan, because I wanted to be a glamorous movie star and eventually president of the United States. And that was he at least provided a pathway for that. I think we've all pretty much on the same page that I'm not going to be a glamorous movie star, but I still very much have public service in my blood, and never, it's not off the table, let's say.
Okay, well, I'll look forward to my 2024 ballot. So Mark, to kick this off, you want to put up the first polling question? And while you're putting it up, I'll just tell folks, the way we generally do this is we often start with a polling question and then have the discussion kick off from there. And I will tell you, as you're completing this polling question, that this particular session is completely unscripted. We did not do a rehearsal. We said unplugged. It's unscripted, it's unplugged, and I don't know what some of the answers are going to be in advance, and also add your own questions as well. So as you know, hospitals are supposed to be transparent. The original fees were very low for 2021. They've just increased them for 2022, and it can be for a large hospital fee, I think over $2 million or something for a very large hospital, $10 a bed day. So love to get people's opinions, and then we'll turn to our guests. How would you forecast the expected effectiveness of these new transparency pricing rules? And just pick one as between trivial, low, moderate, and reasonably effective. Okay, what do we have here? Low. So I expected trivial. So this is what the survey says. Let's see what our experts' opinion is here on hospital transparency.
Yeah, I'm going to have to agree with your 24% on trivial, Al. I think that $2 million is really pocket change or a rounding error to some of these institutions. And when you look at what they have sort of stand to lose when it comes to being fully transparent with their pricing. And, we've seen with some of the ones that have been transparent, 3, 4, 5 times Medicare, complete, subject to variability with their peers in the same region. There's a lot to lose there. So $2 million is a pretty attractive price of doing business at worst. And you know what? I think that there was never an intention to comply. I know that COVID was a great excuse, and I think staffing shortages, all of the things that people are pointing to as excuses as to why they can't comply today. It's all smoke and mirrors. I don't think there was ever an intention to comply, and I don't think there is an intention to comply in the near future.
Well, the way I would look at it is not so much in the dollar figure, but in the dollars per day. I mean, $10 a bed day. What's the average that hospitals, commercial charge for a bed day, right? I mean, it's right. Way into the 4 figures.
Well, and that also, okay, per bed per day. I just don't find it to be meaningful. And I think, if to the extent that we're talking about, I see a comment about rural hospitals, it might be effective, but, I think for transparency and to be a market mover or to be effective at setting the groundwork for a functioning market, which is what we're missing in healthcare, it's got to be an even playing field. That's what transparency is. And so if not everybody's doing it, it's really not, it's for naught, I guess.
Yeah, I mean that I think I would agree. I mean, there's some things that just look like window dressing. On the other hand, it does appear that the No Surprises Act means kind of the end of five-figure ER bills. You think?
Well, it means the end of five-figure ER bills for the patient, right? And I think the media has been very eager to point out these really egregious surprise bills and out-of-network bills that members get, you know, if they're having a baby and they get a $500,000 medical bill, or a COVID inpatient stay that was $400,000. They make great headlines, right? But at the end of the day, if that bill isn't going to the patient, that's a great step in the right direction. But if the bill's still going to somebody, you know, if it's going to the employer's health plan and bottom line for a self-funded client, or, you know, for, you know, it's going to hit a premium for a fully insured client, I think that's a problem. And, you know, in the baseball arbitration that's been set up with the No Surprises Act, you know, I think more to come. I think the clear path to sort of, you know, really negate even needing this very complicated system of arbitration and the QPA and all of these things, right? Like, what if the provider and the actual payer just came to a fair price, as opposed to these hidden network fees and hidden network prices and lack of transparency in network prices?
Well, there are a couple of points to follow up on there. One is that I do think it will get rid of the headlines. But the second thing is there are these wacky fees, and like a facility fees. You know, sure. I mean, and I read that actually there was even a telephonic, telemedicine situation where they were charging a facility fee to talk to somebody on the telephone.
Yeah.
Did you see that?
Yeah, I saw that, and it's absolutely not shocking. So just a little story anecdote about my time in New Jersey. In March of 2020, when you could see, March and April of 2020, when you could see the lines outside of the urgent care centers for COVID testing, I immediately, myself and allies from the treasurer's office immediately said, this is going to be a problem, right? With no cost share and advertisements of free testing here, come get your free test here. How do we get in front of urgent care is charging a global case rate for a COVID test that should only be $100, but now we're paying $400. I mean, it's better than an ER, which might be $1,500. And then also, we know that upcoding is going to occur inpatient. How are we accounting for that? How are we accounting for hospitals not calling every inpatient a COVID patient, or testing somebody 5 times a visit? And I have to say, as much as I sort of beat that drum and tried to get ahead of this issue, I had a former member send an EOB to me the other day. Their son had to get tested weekly for part of his football practice or something. And a member of the state health benefits plan went to the same urgent care every week. I mean, it was a very long list, $450 per test that the state is paying. And it's, you know, it's just sort of obscene that this is happening. And also you're seeing ERs advertise telemedicine, and they're charging ER prices, global case rates for telemedicine visit on the ER, in an ER, which inherently is not going to be, you know, the level that requires the ER, you know, codes. It's not, you can't suture over the phone.
That's that's actually, I thought that was my line, but yeah, I mean, there's certain things you just have to go in for. Now, it does appear that there's a lot of whack-a-mole going on, and that the providers will find a way to take advantage of the system, basically. So let me ask you, we actually think we've solved it, and you and I have talked about this as attorneys for emergency care by taking advantage of the Emergency Medical Treatment and Active Labor Act of 1986, which for the uninitiated means the hospitals can't turn you away for emergency. They can certainly turn you away for elective care. They can't turn you away for anything that any reasonable person would consider to be an emergency. That was how the law was designed. Now, hospitals have ended up, and Chris, you talked about being 3, 4, 5 times Medicare. My observation has been that the cost of emergency care versus Medicare is actually quite a bit higher than the cost of elective versus Medicare. And you probably follow Dr. Bricker, same as I do, on LinkedIn.
Yeah. Yes.
And he explained why that is. It's because in emergency care, because they have to treat the uninsured, they pile costs in for the people who aren't uninsured. Whereas Medicare, a level 5 Medicare, I mean, it depends on your state, but a level 5 Medicare, which for the uninitiated is the highest level of Medicare, we're seeing charges, I'm not kidding, I've seen this multiple times, now in southern states, probably more in New Jersey, but about $673 for something that might be 10 times that amount in network if you're paying commercial. So, so let me ask you, as an attorney, and we haven't talked about this in advance, and we're not, you know, we don't have any financial relationship, which I would have loved to have had in New Jersey, and we'll get to that in a little while. What do you think of the ability of people to basically go in, write in their own financial consent, which we will make available to everybody on this call to the extent you don't already have it, and say, either you treat me for this amount, 2 times Medicare, or you reject this consent and we will take it up in court where we are offering you something very reasonable. Good luck with that.
Yeah, I mean, I think legally and theoretically and logically, it all makes sense. But what I'm going to say is, as I'm putting my, you know, member hat on, and it depends on the emergency setting, right? But to expect a parent that's going to an ER at 2 a.m. with a sick baby to, you know, and I've been that parent, to have, number one, the wherewithal and the knowledge. That's on us as employers to sort of do that education. But when you're, you know, approaching a nurse who's doing the intake, or a medical technician, and, you know, having a battle over a form. Are you trying to, oh, can you not hear me?
I was trying to show the actual form.
Oh, okay.
You're on a roll.
Oh,
you're on a roll.
I think it's, you know, I think it's definitely a tool in the tool chest, a quiver in the arrow. It's a piece of trying to solve this puzzle, and it can work, but I don't think that it can work for everyone in every situation, just because of the, you know, the nature of, like I was saying, you know, you have a mom going in at 2 a.m. with a baby, and she doesn't want to piss off the intake person, right? Like all she wants to do is get her child seen as soon as possible and not get put at the end of the line. So is she going to be willing to even have that debate at that time? Probably not. I don't know. I probably would, but I'm different. So yeah, I mean, I think it has its place, and I think one of the benefits of that kind of education is really empowering people to become more involved in their healthcare decisions, whether they're using that tool in the toolbox or others. I do think that it can work. It's just not going to be sort of the panacea of, you know, solutions.
Yeah, and I would actually, and once again, have not talked about this in advance, I would actually completely agree with you. And when we do our ROIs analysis, and we have our little ROI model, we basically assume that about 5 to 10% of people will actually do this if, in fact, you've educated them, you've waived the copay if they do this, you know, I mean, there's ways you could get it to 15 or 20, but it's not going to go above that. The thing is, the difference in cost is so mind-blowing that you can actually break even on all Quizzify with like 5% of people using this. So I think this is great. So thank you for that. And Mark, let's go to the next and change the subject up a little bit. Let me see what's next on the list here. Okay, so we've just discussed that you know, providers. I mean, the ones on this phone call, by definition, if you join this phone call, you're an honest provider, okay? So I don't mean to say anything unkind about you, but who takes the most advantage of the current dysfunctional system? Is it providers, carriers, wellness diabetes vendors, and point solutions, PBMs, or all of the above? And while we're getting the votes in, let me ask you what you think on this, Chris. If you had to pick one, or maybe you think they're all,
So, I mean, I think to me, who takes the most advantage is, I'm going to call out the carriers on this one. And if you want me to wait, I can wait to sort of give my explanation to see the poll, or.
Sure, let's take a look at the poll.
Okay.
Okay. Oh, we have all of the above.
Yeah.
Yeah, I think it looks like the people who did not pick all of the above agree with you. Now, the fact is, I don't think we actually have any carriers on this. You can say whatever you like. So how do the carriers take the most advantage? And I would have actually voted for the PBM. So I'll talk about that in a sec. But while you do that, I'm going to actually call up a slide I have from a PBM.
Sure.
So yeah, talk about the carriers for a minute.
Yeah, I think the reason I would pick carriers over the other answers is not, from a market share perspective or actual dollar impact. It's more the egregiousness, I think, on the carriers, because we all know what PBMs do, right? And maybe those on the call. I think the reason I would say carriers is because they take advantage of the dysfunction. The others are really not a product of the dysfunction. They do prey on it as well, but the carriers are really responsible, in my opinion, for the continued promulgation and sustaining of that dysfunctional status quo. Point solutions, I think that they have a place and they exist within this status quo. But if you were to remove this dysfunctional system, they still, I don't know, they can bring value in the right system. In today's world, we just talked about hospital price transparency, right? You've been told as a self-funded employer that the reason you need this network and this carrier and this TPA is because they negotiate the best rates for their network and they have the best network. Well, in today's world, right, with some transparency, we now know that in many times the cash rate is half or less than the negotiated rate, or the negotiated rate that they've negotiated on your behalf is actually a lot higher than all of the other carriers. So I think the value proposition has been eroded. And I think there's sort of this clinging on to the dysfunctional system, or a system that works very well if you're the one profiting from it. I think it's, I'm 51% carriers, 49% all of the above.
So a couple of observations there. One is that we do very well selling to employers, but we've never actually signed up a carrier. And one of them very candidly told us why, which is, essentially that we would be undermining their business, because particularly with the EMTALA thing, we're getting a better price in the ER than they are by far. And we also had, now this person's actually on this call, so if she wants to step forward, I don't think she will, but feel free. We also had somebody that we talked to, a couple of times from a major university system, who declined Quizzify specifically because this university system has a hospital that's affiliated with it that gets about 70% of its patients. And they said, if the president ever found out that we were getting a better deal than they had negotiated for the hospital, if the hospital got upset and told the president, I'd lose my job.
Right.
So, you want to know where benefits costs are so high? It's because people can't get in trouble for paying the best price.
Right.
So, I would also look, let me just see, we have a lot of folks saying that, the carriers, and then somebody said, I know Al's preference on that. Well, Al's preference is actually, we'll get to the point solutions and the wellness vendors in a minute. The only reason they're not number one for me is that the PBMs have so much more money. There's so much. They started out there's a saying in political philosophy, a guy by the name of Hoffer, I think, I've never heard of the guy. I think he's just famous for this one saying. He says, every movement starts out as a cause, becomes a business, and degenerates into a racket. That's the PBM industry. When they started, I mean, everybody thought this was going to be the best thing. And the reason I bring them up, and unfortunately, I can't bring up the slide that I thought because I'd have to like text, they have a two-level authentication, but I got a note from the PBM that my wife's employer uses, Optum, that has all the drugs, which is in my case, monthly Ambiens, generic Ambiens, and how much I paid for them. Now, I used to pay a $15 copay, and my wife's employer would get billed another $20 or something like that. I then switched, and I'm going to use a name here because they've been on this show, Drexy. I then got a Drexy card. They were kind enough to give it to me for free, but I'm not offering this in exchange for promotional consideration. With this Drexy card, I was able to go to Walgreens and get the same exact generic Ambiens for $3.47, with zero being paid by my wife's health plan. Now tell me how that should even be possible, right?
Right. Yeah.
Yeah. So now let's get to point solutions here, and I'm going to share. Well, let me just pull up the right slide here, and then I'll share my screen. So you're the first folks that we've had on here who are not Quizzify users, or you were not Quizzify users. I mean, we've talked about it a lot, but you were Livongo users. So I'm going to share my screen, and you're going to see the Livongo Amazon reviews. Let me see. Here it is, right here. Okay, so I'm not going to offer an opinion because we're on the record here. I don't want anybody to think I'm, saying something. It would be impossible to slander this thing. There I go. You just can't stop me, right? But so the question here is, what does Livongo have that we don't?
Right.
Why use Livongo and not Quizzify?
So, I mean, I think Al, there's a lot to unpack there in that question. When it came to a diabetes management solution, right, it was a very specific area that we could see in our utilization reports that needed to be addressed and was not being managed properly, right? So it's one of those things that maybe it feels less like boiling the ocean and more like focusing in a very specific area and being able to take action, whether or not that was the smart action or the right action, or it was the best vendor to take that action. Let's leave that for another day. But I think that that's probably from if you go into a room with your health benefits consultant and you're looking at a healthcare spend, $5 billion, right? And you look at your top cost drivers, none of those categories are going to be healthcare illiteracy. Like, that's not a category that you can address in today's world. I feel that it's a huge category and a huge opportunity to address spend across the spectrum. But, I'm human as well. And I didn't have the, whether it was the acumen, foresight, or, power to say, let's create a new category and address healthcare literacy. I do think that it's becoming more and more mainstream to talk about, like with Marshall Allen's work and Never Pay the First Bill, with Quizzify, and some other, I won't say niche vendors in the healthcare literacy space, but learning that health literacy will be, I think a lot of these folks are trying to do like not in-home offerings, but homegrown offerings in terms of healthcare literacy. But anytime you're sort of piggybacking off of a point solution and then addressing healthcare literacy, I get a little nervous. But that's the explanation I'll give as to why, why Omada, why Livongo, why Hinge, why, point solutions that can address one of the categories that we have traditionally looked at to say, what can I do to address this particular population that is spending this much money with this comorbidity?
Well, and so a couple of observations there. First, I think you're kind of off the hook for this one because Livongo did not disclose this. to you. They didn't disclose it to me either. I just found it. I'm not sure that it's allowable for them not to disclose it now. And like you, I actually thought that they did do something for the members. They just were making up their financial outcomes. But in fact, as it turns out, they may not even do anything for the members. But who knew? I mean, I didn't know either. I thought it was a financial snooker, but not a health snooker. I thought they were actually doing something valuable. These point solutions in general do tend to do some cherry picking. They start out with people who are diagnosed or high cost or whatever, and they ride the regression to the mean train down, and they also cherry pick participants. So the participants will always outperform non-participants. In fact, it's been proven by a wellness vendor itself that participants will outperform non-participants even if they don't have a program to participate in. It's all in the mindset.
Right.
And the thing you said about health literacy is very interesting. We actually find the same thing, that ironically, I mean, we love the fact that we kind of quote unquote own the market in one way. Another way, we would love it if there were other competitors, so it would become a category, because it's not a category. So when consultants give people a list of all the things to focus on, it's never something that goes across everything. It is always, as you say, orthopedics. My favorite is prenatal these days, diabetes.
Right. Yeah, and it's interesting that one of the other sort of tools that the consultants have in the toolbox is we can change plan design. Like maybe we'll adjust a co-insurance amount or a copay amount. Well, when 95% of your population doesn't know the difference between a copay and a co-insurance, how does that actually impact behavior? So I mean, I think that there's a really strong case for it. But I also think that when you're not adding money to the system in some way, it becomes much more of an uphill battle. Like, I think that's one of the reasons why we really, really need to be cautious about the point solution, revolution or whatever the word is that because we're seeing so much money go into these point solutions and digital health solutions and private equity, when 2021 outpaced 2020, multiple times over, and 2022 will likely do the same. But are we just adding to the pie? Are we making the pie bigger? Are we bringing value and actually shrinking it? And that really concerns me.
Well, as well it should, because it's all once again, some of them may do something for people's health, but the whole financial thing is I'll just say it in general. I mean, essentially every point solution I've ever looked at, with the exception of the very few that have been validated by the Validation Institute, it's all regression to the mean, and it's all participation bias. And those two things multiply together to create these dramatic savings. And this is going to take us into our next topic, and we'll do another polling question. But if you don't have access to your own data, you have to take their word for this stuff. And you really don't want to be in a position, taking the point solution vendors' word for things. Mark, I think the next question is about data. And if not, then we'll talk about data after the next question. Mark? Here it is. Okay.
Here we go.
This is a follow-up to the last question, which is last question was what's most dysfunctional, and this is who's going to fix it the best. And the choices are federal government, carriers, disruptive next generation PBMs and advisors like Health Rosetta, disruptive TPAs, employers, individuals. So while we're polling the group of your choices, which one would be first or second on your list?
Well, I think the federal government, no, I'm just kidding. That was a joke. My attempt at a joke. Not the federal government. They're going to be last. The employers, they're my strong first place. And I think employers followed by, I'm going to say disruptive next gen companies, because I think if employers lead the way, they need partners there waiting for them to take them on the rest of the journey to value. And I think that there are companies in that category that can do that.
Mark, survey says? Okay, so in this particular case, I would agree with you, but I would flip it a little bit. Because dealing a lot, and we know a lot of the same people. We know the Dave Chases of the world, Dave Cantor. I mean, we know Michael Bro. I mean, all these folks that they often will get a group, and then it's still an uphill battle to convince the group to kind of take things to the next level. I mean, groups are very reluctant to let go of the of the status quo.
Absolutely. But I think that regardless of their reluctance, when it comes to the ability to effectuate change, like you said, you, me, Dave Chase, those sort of, I don't know, whatever you'd call us, influencers in this space, in our LinkedIn communities, we can believe in change all we want, but I'm not purchasing healthcare for 200,000 of my employees. I'm not doing that. I'm trying to help people that are doing that. And I think that purchaser, that employer, 67% of, I'm blanking out, 67%, I believe, of like healthcare coverage is through employers today. And they are the purchasers. And if it's, the rest are probably federal or state governments. Those 67%, those employers, they have the tools, they have new tools with the ERISA, fee disclosure rules, ownership of data, restrictions on gag clauses. Again, I think again, it's sort of a close tie, 49-51% on who comes first. But the employers have to be willing to take the leap. And it's incumbent upon leaders like, yourself and myself and the Health Rosetta folks of the world to get them there and to tell that story. And, we'll be waiting there with open arms with the disruptive technology and solutions that can take them the rest of the way.
And there's a couple of questions coming in on this. Somebody said absolutely about the point solution. So score one for me on this. And the next comment is, employers are risk averse and yet don't understand the risk associated with standing pat with a traditional carrier or TPA. So which to your view is riskier?
Yeah, so the point about risk is a really interesting one, because I think I agree with that. I think that there's a risk aversion there, especially for HR offices. Like they've become healthcare companies themselves, dealing with COVID and return to work and all these things. And sometimes they think, I just can't I can't be a maverick in this space. I'm just going to do what I've always done, right? I think what we need to communicate and do a better job communicating is the risk of not doing anything. Like right now, you are sitting in a fiduciary seat. If you do not look at the reasonableness of the fees you're paying to your point solutions, the Livongos of the world, if you're not looking at the fees you're paying to your broker and how they're paid, and if you're not doing an evaluation of the reasonableness and benchmarking it to see if it's, you're actually getting value, you have a real risk of fiduciary liability. And so maybe we position it not as you being progressive and forward thinking and doing, being a maverick of the healthcare benefits world, but maybe this is the ultimate risk mitigation strategy. And I think that might sit differently and possibly, better with the C-suite in these large employers.
Well, I think you've got a great point there. And in fact, we have somebody coming on, I believe, in March, another, like I say, we only do the all-stars here, my friend, whose particular specialty, his name is Doug Aldine. I think of him as being the leading, Doug, right?
I know Doug,
yeah. Sort of the leading disruptive fiduciary / ERISA attorney in the country. He also, by the way, is one of the experts on our 24/7 EMTALA line in case somebody gets in a difficult conversation in the middle of the night. They call an 800 number, and he gets interrupted in the middle of the night, literally, even if he has a snooze button on. This number goes through. Oh, hey, by the way, just to wrap up that particular point, it actually does turn out that literally every hospital will accept the consent in the sense that if you put that down and they treat you, as you know from an attorney, if they don't say anything, that's offering acceptance. Where the problem comes in is hospitals have a way of forgetting that they accepted this consent, and they send you the old-fashioned bill. We used to resolve those ad hoc, but now we've actually created a formalized process where we will take the bill, get it rebilled, and basically see it all the way through to the end. So just to wrap up that piece. So that is a very, very interesting idea that instead of trying to sell upside benefit, we sell what HR folks are most concerned about, which is getting in trouble.
Yes.
Because I feel like in HR, that is a very important thing, is to that you're doing your job best if nobody notices it, kind of thing.
Right. And that's very true.
And I don't mean that in any,
it's not a bad thing. The HR office, they don't want to get that call about the formulary changing, about Susie not getting her medication, or this claim being denied. It's a area where, you don't want the phone to ring a lot, because that means that people are by and large happy with what they're getting. Right. And so there is this sort of like, and we even use language that has negative connotations, like disruption, like abrasion, like friction. These are words we use to describe change in that area. We should really just change the way we talk about it, even, progress, forward thinking, more positive feeling words than negative, I think could go a long way.
Yeah, no, once again, I think you're absolutely right about that. And I didn't mean anything whatsoever judgmental about HR. I mean, there are certain jobs that are done best if they're not noticed. If you go to a conference and you don't notice, that means the production was done very well. You're just focused on the conference. The food is good and the thing runs on time. You take it for granted, And I actually personally make a point of, when that happens, of mentioning the contest organizer. I say conference organizer. I say, quote unquote, sometimes it takes an awful lot of effort to make something look easy.
Yeah.
Now, to your point about HR, one of the things that I've suggested, and actually, David Contorno as well, and he and I have had this conversation, is that instead of focusing on how much cost you're going to save, I say it's a very simple formula, Dave. A plus David, he goes by David as opposed to Dave Chase. I said, Dave, it's a very simple formula. A plus B equals C, where A is cost savings, B is employee satisfaction, and C is the total. And then you say, we can do things better. As an employer, it's up to you. Do you want to turn up the juice on A and keep B the same to get to a high C? Or do you want all the benefits to go to the employees, turn up the juice on B? Maybe your own spend might not change, but still the C number is good. So that the HR person feels they have some control over how the employees feel, and that they're not getting this dramatic cost savings at somebody's expense and the phone is going to ring.
Right.
Let's see. Now, I have an opinion on this. I'll ask you first, because obviously you're the guest of honor here. It seems, how come employers don't seem to care about how high healthcare costs are getting every year? That is kind of my experience as well. Yeah.
So I think that perhaps it's not that they don't care. I mean, they certainly know. How does a CEO or a CFO not know the second largest line item in their budget, right? I think where they miss is their understanding that they have options and they have the agency to change it. I think oftentimes, and my own husband, who's a COO of a national scrap metal company in the US, and I try and talk to him about health benefits, and he's just like, that's not what I do. I don't want to have this conversation. That's a different office. And it's that there's like this mentality that it's this runaway train. It's this abstract thing that they have no control over, because they read the Wall Street Journal, they read the New York Times, and they see healthcare costs going up X% year over year. And they just think that they're sort of a victim to this thing that is moving along and they are along for the ride. I think the real challenge is educating, finding proof points and winners to say, no, you, self-funded employer, have the agency and the power to do something about this. But then you also then have the hurdle of convincing the leadership and the HR folks that, you know, just doing the right thing. Nobody wants to change benefits because they're worried about their employees and, you know, all those negative words I just said, like abrasion or friction or whatnot. So I don't think that they're unaware of rising healthcare costs. I think that there is a fundamental misunderstanding that they have the power to do something about it.
I would, and I'm going to offer a quote unquote disruptive opinion here, so you can, would love your comments on it. I think it's actually more insidious than that, in that I think a lot of vendors have figured out that people in HR are managing their administrative budget vastly more tightly than their medical spend. And as a result, you can, for instance, take a PBM. You can raise the cost of drugs all you want, as long as some of it goes back in a rebate that hits medical spend.
Right. Yeah, no, I don't, I think that that's one of the areas, certainly in public procurement and probably in private sector as well, where we're buying healthcare all wrong. You know, I don't care, I shouldn't care, or at least not put all the weight on what the PM cost, the administrative cost is, you know, $25, $30 per member per month. When that's 1% of my total spend from a medical, like if I need to pay double that, but I'm getting my members wrapped up in the right services and good quality care and high value steerage and advanced primary care, et cetera, like I should be able to, I should be willing to go there. But the way that we have by and large run procurements and chosen carriers and our vendors in this space is, what's the size of your network? How big and bad is your network? Well, that's a horrible way to buy healthcare, right? I mean, we don't want our members going to Dr. Hack to get their knee cut open. We only want our members going to the best doctor who performs that surgery 400 times a year or whatever. So we're doing that poorly. Then we're basing our analysis off a discount. I don't want a discount. I want a unit price, and I want a guarantee of a unit price year over year. But we buy based on how big is your discount without any unit cost guarantees. The problem number two. So I think that, you know, we're buying things, you know, not in the smartest way. But yeah, I mean, I think that we're in agreement, and we could talk about that topic a lot.
Oh my goodness, we could stay. I mean, we have not lost any of our audience, and we can stay on the phone forever on this. So there is actually a couple of vendors, and I don't mind mentioning names. Catalyst is one of them. They do this with the state of Arkansas, which is not New Jersey when it comes to sophistication and their benefits. I'll tell you that. They have figured out that they can do a wellness program and put it through claims, medical claims, and charge twice as much as the already rip-off fee that they would be charging if it were an administrative expense. And then they, in their advertising, they advertise that you don't have to worry about your administrative expense. This won't hit your administrative expense.
Right. Yeah, that's not uncommon. I think with more and more, I think you see point solutions that recognize, if it was, and Al, this is in public sector, this is particularly true. If it were an administrative cost, that entity would have likely had to go through a public procurement process to bring them on board, because it would be another contract that they would be a party to. However, if Catalyst simply becomes an in-network provider with the carrier that the state or whomever is contracting with, they bill it through claims. There's no direct contractual relationship needed. They're just billing it through claims as an in-network provider, and you've essentially skirted that whole process, right? And yeah, and I think too, you know, give a little shameless plug. And again, this wasn't scripted, just so everybody knows, but one of the services we perform at 4C Health Solutions is really unpacking those types of things that our employers don't know about. So through our invoice reconciliation process, we can see if things are running through your claim file that you either aren't aware of or you didn't know the amount, because we're able to say, okay, these are the claims, and these are actual medical claims. Now these are being run through your claims file and being taken out of your self-funded account, but they're missing these 10 fields, which tells us it's not an actual claim. Maybe it's an admin fee for a wellness vendor or some other capitation fee. And a lot of the time our clients are saying, well, I didn't know I was paying that. And when approached, the carrier says, yeah, it's just going through the claim file, so you don't need to know about it. So it's a real issue, I think.
And then if the carrier finds it and they quote unquote negotiate it down, they keep a piece of it, right?
Right. Yeah, that's the biggest racket, I think, is, an example I like to give, right, is turning off, for example, like turning off a readmission edit. You turn off the readmission edit that would have otherwise, not paid $10 million in claims in a year because they were readmits that should have been subject to a readmission policy. Not only did you pay that $10 million out that should have never come out, but then the carrier decides, oh, I'm going to go get it back for you. And then they take a big cut off because they were, kind enough to go after the claims that should have never been paid in the first place. Very, very common. And we see that a lot, especially, if you're offering claims or claims review services or payment integrity services, the carrier is telling the client, oh, no, we do that for you. And we only charge you, X percentage, and we saved you this many millions of dollars last year. But they were the ones that were responsible for watching the door in the first instance. I mean, talk about misalignment of financial incentives. But it's surprising how few purchasers of healthcare are actually paying attention to that.
It's surprising how few purchasers of healthcare are paying attention to anything at all. We're running out of time. We have one more polling question, and then I think we have a few questions from the audience, don't we, Mark? Because this is the last polling question here. Yeah. So a lot has to be disclosed at the end of 2022 about fees and rebates, spending patterns. Will this discourage some of the sketchy financial arrangements? And while we're getting the panel's response, what would your take on it be? None, a few, many, or most?
It will discourage. It should discourage many or most. Will it work? That's a different question, and I think we have to be prepared to play whack-a-mole. To your point, I'll get into it after we close the poll, and I'll give an explanation as to why I say that.
Okay, survey said, oh my goodness, a few. Okay, so this is one case where you're more optimistic than others.
It is, and it goes back to that empowerment for employers, because you're attaching a fiduciary liability. And I think this is where we also should really educate our labor leaders as well, and our organized labor who entrust their dollars, whether it's with a board that runs their trust fund or their management that runs their health plan on their behalf, to really hold them to account with enforcing that fiduciary obligation. So one of the reasons I say it's going to be a little bit of whack-a-mole is what we're already seeing in the market is that the CAA fee disclosure rule and some of the, again, rebate spending patterns, et cetera, we need to be on the lookout for ways that they can get around that. And one of the ways that we've seen is that they're now tacking on those fees, brokers, consultants, et cetera, tacking them on to voluntary benefits like your dental and your vision. So they understand that I don't have to disclose it with my health benefits that's subject to ERISA, but if I put it into my dental, vision, other voluntary benefits and tack that admin fee on there, I'm not subject to those disclosure rules. So we need to pay really close attention to the way that this is going to evolve, because anytime you're out there and there's money to be lost, they're going to try and make up for it somewhere. Excuse me. But I am hopeful in this space.
Well, I've seen a couple. I mean, first of all, incredibly, Livongo and Mercer, back before they realized this wasn't such a good idea, actually announced that every time Mercer puts Livongo in place, they get money for it. I mean, I don't know what they were thinking, right, but it's an announcement. But what we found is that, and this was a really good example would be Accolade and Aon, that Accolade pays Aon a lot of money for their actuaries to say that Accolade save money, but then they wouldn't pay when Aon actually puts them in place. And my understanding is that there would not have to be a disclosure of this completely separate income stream for Aon.
I'm not familiar with that particular example, but that sounds right. I mean, what you're saying doesn't seem odd to me at all. I think unpacking, so the new fee disclosure rules requires disclosure of both direct and indirect fees. And I think the indirect is going to be really, obviously, the more interesting areas to see how these financial arrangements really play out. I'm still optimistic. That being said, I don't know if your viewers saw the most recent Department of Labor guidance that came out. I believe it was issued on December 30th, 2021. But it was kind of a non-enforcement enforcement memo. Basically, you put forth good faith efforts, you're going to be okay. So I think, folks like your next guest, Doug Aldine, and the others in the legal community, in the labor community, and in the employer community really need to use that, use the CAA as robustly as possible in order for it to, really hold or realize the promise that I hope it holds.
Well, I will say that the folks, and I know a lot of the folks at the state on the labor side, and they're very, very forward thinking.
Yes.
Not sure that's going to be the case everywhere. I think we have time for one or two of the 3 or 4 or 5 questions that have come up from the audience lately. Mark, you got anything there?
Yeah, just to follow up on what we're just talking about with these CAA rules around the disclosure of commissions and compensation that brokers are now going to have to make to employers. How might that actually impact some of the things we're just talking about in terms of progressing to better healthcare solutions?
Yeah, I think that there's a lot of promise there. I'm hoping that things like overrides are now going to be front and center, and an employer is going to know that when a broker, basically says, look, I'm not even going to take a commission on this. Meanwhile, the firm's getting a big bonus from Anthem for delivering a bunch of lives in a given year. That type of disclosure, it's going to serve a couple of purposes. Hopefully it leads to cost savings, directly. Secondarily, I hope it leads to a more engaged and sophisticated purchasing group within the employer community that now has to come up to speed in the healthcare world and how to purchase and better manage their spend. Again, I think what this does is it makes being a sophisticated and engaged consumer, when I say consumer, I mean the employer side, not aspirational, but really sort of an expectation legally.
Well, that's a great place to end, and we like to end on time so we can brag about how we never lose our audience. There are some more questions, and we'll send them to you.
Okay.
In an email, Excel spreadsheet, and you can comment on those. Some very good questions came in late. So once again, this was a great conversation, even by the standards of our webinars, which are always great conversations. And we thank you very, very much for participating, and we thank the many, many attendees who came and hopefully got something out of it. So, yeah. Any final parting word there, Chris? Or
no, just thanks so much for having me, Al. And these kinds of conversations are so important. And and I hope people that are listening share content with other not like-minded people, but those that need to be brought into the fray. I always get nervous about echo chambers. I don't want to exist in an echo chamber. So let's amplify outside of our communities.
And my final parting words will be good to everybody on this call. Good luck with that.
Thanks.
We're all preach to each other, and we're all right, and we just got it managed to penetrate everybody else. So thanks again, and we will talk to everybody soon in a follow-up.
Thanks.